Hi, well, thank you for the introduction, Mark. So today I'll be talking about managing motor complications. So this includes like on-off periods and dyskinesias, and as well as orthostatic hypotension. And I'll also be talking about like new medications, but also the medications that we use for management currently. Just a graphic of the different stages of Parkinson's disease, and here will be like motor complications, and here are non-motor complications below this line. And the topic that I'll be focusing on are fluctuations and dyskinesias, as well as the non-motor complication of orthostatic hypotension. And I know here it just like puts it in the column of mid-stage Parkinson's disease, but if you have these symptoms, it's not necessarily meaning that you are like advanced or mid-stage. It's just that you're advancing in the Parkinson's disease. This is another graphic here. It's just like to show like as the disease progresses, the therapeutic window, so the window that when you're on kind of gets narrower, and off time increases, as well as dyskinesias here. And then this little black line or curve are the blood levels of levodopa in the system. And as you can see, as the disease progresses, you spend more time like in these dyskinesia or off time phases. So identifying motor fluctuation is probably the most important thing. You need to figure out what symptoms get worse, especially after the medication starts to wear off. And these symptoms, does it improve with the next dose of levodopa? One thing you can do is keep a symptom diary, just kind of keep tabs of what symptoms pop up and where it is in correlation with the levodopa or your medication dosing. So I have a link here. I don't know if Mark typically sends out the PowerPoints, but like these are hyperlinks that you can just click on and it'll take you to the resources. So motor fluctuation, like the tremors, freezing, those are obvious when you start experiencing them like on and off. On meaning the medications are working, and off meaning that you're having your PD symptoms. But then there are also non-motor fluctuation, and this includes like feeling anxious or irritable, having some cognitive problems, feeling tired, having pain, or even sweating. So just some background. So if you are on levodopa, and when I say levodopa, it's the Cenemet, so carbidopa levodopa. This is absorbed in the small intestines, so diet actually affects how it's absorbed. So protein compete with levodopa transport. So this is just like a little animation here of this little yellow blip are levodopa, and then this is the transporter that helps carry the levodopa over into the bloodstream from your intestines. And the blue dots would be like the protein that kind of competes and block the transporter from bringing levodopa into your bloodstream and therefore like into your brain. So high protein diet can increase the protein that competes with your levodopa. And then gastroparesis, which is a complication of Parkinson's disease, it just means slowing of the gut motility, can also impair absorption. So this is the reason why when you start levodopa therapy, we tell you that it's best to take it on an empty stomach if you can. There can be side effects of nausea, and that's the case, then maybe take it with like some protein neutral or low protein food. And if you want to take it before meals, we recommend 30 to 60 minutes before meals. Or if you take it after meals, wait a little bit longer, like 60 to 90 minutes, because like I said, gut move is slower, so there's still food in the stomach that you want to wait till it clears. And this is a chart here of just common food and their protein content. So beef and fish, chicken will have higher protein, and like veggies that are cooked will have a little bit less. So the easiest thing to do is if someone's complaining of lots of on and off periods, or what we call motor fluctuation, and they're on low dose of levodopa and is tolerating it without side effects, normally increasing the dose of levodopa can help on-off periods. And in more advanced PD, and especially those with dyskinesias, like these extra wiggly movements, which can be a side effect of levodopa therapy, or other side effects, another technique we try is what we call dose fractionation. So splitting up the doses, the daily doses, but more frequent doses at each timing, you take a little bit less of Cinemet. So you still, example here, this is like 2 Cinemet 3 times a day. So 6 Cinemet tablets daily, and then break it up into 4 doses, but 1.5 tab each time. And only caveat with this is sometimes if you're on a lower dose of Cinemet, you're not quite meeting the threshold for therapy, so then you might not have like the on effect. Another strategy we use is using a longer acting oral levodopa to help with the motor fluctuation. The one that some of you guys might be on are the CR tablets of Cinemet. And it's good for bedtime use to reduce nocturnal or early morning wearing off. The disadvantage is it does not absorb well as immediate release, and it takes longer to kick in. So the bioavailability is not as great, so you need sometimes a lot higher dose to get the same effect. And then the newer medication is the extended release capsule, or Rytary, which have beads of the immediate release formulation and the controlled release. So there's a combination. And because of that, it's good for using, it's good for motor fluctuations during the day. And you can reduce the number of daily doses since there is like the longer acting effect of it. Can also be used like the Cinemet CR with a bedtime to help with nocturnal or early morning wearing off. And for people with swallowing difficulties, you can actually open up the capsule and dump the beads onto like applesauce to take, and it'll be easier to swallow. It can also help with peak dose dyskinesias, and I'll talk about dyskinesias later on in this presentation. And the disadvantage is it's a difficult conversion going from Cinemet IR or CR to Rytary. So there is like a window where we might not get the perfect dose. So that needs to be adjusted, and it might take a while, and it is expensive. The next approach, if adjusting the levodopa formulation or the timing of it doesn't help, then we have like adjunctive therapies, which can help reduce off time, but there are side effects and it can actually worsen dyskinesias. And if that's the case, sometimes we might have to adjust the levodopa dose or the Cinemet dose. So these medications I'll talk about in further details in the next few slides are dopamine agonists, COMT inhibitors, MAO-B inhibitors, and the newer one, adenosine A2A antagonist. So some of you might be familiar or might be on these medications. So the dopamine agonists includes the pramipexole, so Mirapex immediate release, and there's the extended release formulation, ropinirole or Requip, also immediate release and extended release. And there's the reticotine, which is a patch, and the trade name is Nupro. So these is just an example of the patches. And it can reduce your off time, so time when you are having symptoms, from up to 2.5 hours a day. But there are side effects. So it increases risk of hallucinations, peripheral edema, so swelling in the legs, can have daytime somnolence, can cause low blood pressure, and this thing we call impulse control disorder. And this is something we screen for in clinic if you're on these medication. And that just means like we ask about if there's any gambling issues, any compulsive shopping, or like compulsively doing hobbies where you can't stop, even like eating and, you know, having like a compulsion for eating. And because of these side effects, especially like hallucinations and drowsiness, we use it with caution in anyone older than 65. The next group is the COMT inhibitors. So these are usually taken with levodopa, and it increases the levodopa effect. So it reduces the off time. The one that's been out longer is entacapone. There is also a combination pill of carbidopa, levodopa, and entacapone together called Stalevo. It's more convenient, but it is more expensive because anything more convenient is usually more expensive. But the side effects are similar to like levodopa, so you can have dyskinesia, somnolence, low blood pressure. In addition, it can cause diarrhea and a harmless urine color change, but for some people it might be like weird. The newer medication is apicapone or Agentis, and it's more convenient than entacapone since it's a once daily pill versus entacapone where you normally have to take it with your Cinnamate. So you're taking Cinnamate 4 times a day. Usually it's like 4 times a day of entacapone. Patients have less risk of diarrhea and there's no urine discoloration. And normally someone that's on COMT inhibitors, it allows us to sometimes reduce the dose of levodopa. So if you're having side effects with levodopa, that can be reduced. And this is just a little chart showing the study that showed apicapone was better than placebo in reducing the off time. And next class is the MAO-B inhibitors. And these prolong the half-life of dopamine in the brain and can reduce or decrease the wearing off. The benefits are similar to the previous class of medications, the COMT inhibitor. So Rezagilene is probably the most popular one, so Azilect. Studies have shown that it reduces the daily off time by about an hour. Selegiline is another medication in the same class. And then sulfonamide or Xadago is another medication. Side effects are usually GI related, dry mouth, headaches, and dyskinesias. And theoretically, there's cautions with like other MAO inhibitors use, as well as tramadol, mipyridine, Flexeril, and then also we kind of are hesitant to use it in people who are older and having more confusion. So this is the new medication, adenosine A2A antagonist, or estradefylline. The trade name is Noriance. It was approved by the FDA over a year ago in August 2019 as an adjuvant treatment to levodopa. It's like one of the first medication, I think over 20 years, that was approved by the FDA that's not a dopaminergic agent. So studies have shown that it reduces the off time about by an hour, and it's convenient because it's a once daily medication. And side effects are similar to the ones I've talked about before: dyskinesias, dizziness, constipation, nausea, and hallucinations. And then another set of medications are these on-demand rescue medications. So these are for patients who are having just sudden or unpredictable off periods. So not so much clearly, 3 hours after you take your levodopa, you start to have off periods. It's for these in more advanced disease where you take your Cinnamate, your levodopa, and then you're expecting it to last 3 hours, but all of a sudden you have like an off period 2 hours or 1 hour in after you take your levodopa. So this is like what we call unpredictable off. So there's this inhaled levodopa. The trade name is Inbrija. It was approved by the FDA in December of 2018 for off periods. So this, since this is inhaled, it bypasses the intestine. So it increases the onset of therapy. So, but however, when they looked at it, it didn't really improve the time spent in off state compared to just taking levodopa. Side effects include cough, upper respiratory tract infection, and nausea. So other medication, rescue medications, apomorphine. There's the subcutaneous and sublingual formulation, and this is a potent dopamine agonist. So FDA has approved the injection, the subcutaneous injection pen, Applican, and the onset of action is rapid. There is some like hypotension, nausea, vomiting side effects, and it can cause skin nodules or bumps under the skin where you're injecting. And there's also risk of like heart rhythm problems. So normally we get the EKG before starting. There's the subcutaneous continuous infusion of the same agent, but it's given through the skin via or subcutaneously through a pump. And right now it's approved in Europe, but still being reviewed by the FDA here. So I won't talk too much about it. And then there's the sublingual apomorphine, which is the film in different doses. It was approved this year in May. It can reduce motor symptoms in about 30 minutes. Side effects are related to like the sublingual aspect of it. So mucosal edema, dry mouth, tongue pain, can cause nausea, sleepiness, and dizziness. All right, so now I'll focus on dyskinesias. So like I said, this is something that's seen more often as the disease progresses. And I'm pretty sure most of you might know what it is, but here's an example. So Michael J. Fox would be a good example of someone with dyskinesias. Let me see if it will play. So he's like wiggling. So when I in the clinic will ask the patients if they have like the wiggly, so like the kind of like squirming your seat, kind of like you need to use the restroom. And for some people who are not familiar with it, they might confuse it with like tremors, but this is more like a squirming motion than like a rhythmic tremor. So one important thing that we, like as clinician, that I want to know is when the dyskinesias occur. So is it on when you're having the effects of the medication, what we call peak dose? So like when the medication kicks in, it's a side effect of the medication. It can cause dyskinesia. So usually that happens about 30 to 90 minutes after taking levodopa, or in some people, the dyskinesias come out as the medication is wearing off. So that's also good to know, because then I will change the management. Risk factors for developing dyskinesias is so younger age of PD onset. We see that they tend to have more dyskinesias. Longer duration of levodopa use. Women tend to have it more than men, but that could also be due to other factors like low body weight, which is a risk factor. And another important question we ask is, does it bother you, or does it bother you enough that you want to get it treated? Because for some patients, when I ask that question, they're like they're not even bothered by it. It's a family member or spouse or friends who like pointed out them, like the patients might not even notice it. So if it is bothersome, then that's when we would consider like changing management. And if not, then it's something we just monitor for now. All right, so management for it would be reducing dopaminergic drugs, so the like levodopa and dopamine agonists, those kind of medication. So think about lowering the dose or lowering the other medications, especially if we added something and the dyskinesias start, then we start removing the medication that we just recently added. Going back to like what I mentioned for the on-off, dose fractionation, so splitting the dose into more frequent dosing, but the same amount. Switching to a longer acting levodopa is another consideration. Or starting a new medication that has anti-dyskinesia effect, such as amantadine. And in studies, it's been shown to reduce dyskinesias by 25 to 50% compared to placebo. So that's like just a sugar pill. There are an immediate release and extended release formulation. Extended release is the brand is GoCovery. And then side effects include swelling in the legs, confusion, psychosis. Can have mottled skin, which is called livedo reticularis, and it can cause insomnia since it does break down into kind of like a amphetamine, like a stimulant metabolite, so it can keep people up if they take it too late. So normally we recommend taking it earlier in the day. And if all that fails, there are continuous drug delivery method and the deep brain stimulation, which I'll talk about in the next few slides. So Both of these are relatively new, continuous drug delivery. So there's the continuous levodopa carbidopa intestinal gel. So same thing that you're taking orally, but now in a gel form that goes through a pump. There is surgery involved to create a like connection between the outside, from your skin to your stomach to increase like the absorption. So it bypasses most of the stomach, goes into the intestine and is absorbed there, and can reduce off time. The risk factors for Duopa pump are complications from device insertion, can cause abdominal pain, and there's the risk of infection. And then there is the continuous subcutaneous apomorphine infusion, so below the skin. It's, like I mentioned earlier, it's under FDA review, but it's been shown, like in Europe, where they're using it to reduce off time and improves on time without worsening dyskinesias. Side effects include like heart arrhythmia, skin nodules at the side of the where they're administering the medication, hemolytic anemia, there's nausea, and then also hypotension, so when the blood pressure drops when you stand up. And for these patients to be considered, you kind of need to have a benefit from levodopa to have benefit from this. And then the other more like established effective method of reducing off time and dyskinesia is deep brain stimulation. And I don't know if there was another talk that goes more into detail about this, but I'll just touch briefly on it. It can be performed bilaterally to improve like symptoms on both sides of the body, and it requires periodic programming to address motor complications. There are two common targets. So one of the targets is called the globus pallidus internus, or GPI. And if this is the target, there is some anti-dyskinetic effect from it by stimulating it. And the other more common target is the subthalamic nucleus, or the STN. So if you do go that route and are being considered for DBS, there's like this whole conference we go through. We do testing on off when you're on your medication, off your medication, to see what improves, and then like do other cognitive testing, MRI scan to look for any problems that could arise from surgery. And then and after that we decide if it's GPI or the STN that will be the target. And deep brain stimulation allows for possible reduction in levodopa. So if you're having side effects like dyskinesias due to levodopa, it allows us to reduce levodopa and therefore improve dyskinesia that way. Make sure, okay. Orthostatic hypotension. So patients with Parkinson's disease present with varying degree of autonomic issues, and this risk increases with age and disease duration. So orthostatic hypotension is basically a drop in blood pressure when you go from like sitting to standing, or like from lying down to sitting up. And usually it's symptomatic, and you would know, so 20 to 60% of patients usually have orthostatic hypotension, depending on what studies you look at. And medically, it's defined as a drop in systolic blood pressure, so the top number on your blood pressure monitor of at least 20 points, or a drop of at least 10 points in the diastolic, so the bottom number, within 3 minutes of standing. And this being recognized, that it could be delayed up to like 10 minutes as well. And patients normally would know if they're having it. Like, we ask these screening questions as well, like about lightheadedness, and if you have it, does it come out when you change positions? You can feel like you want to faint, or actually faint, which is called syncope. It can be vision changes, so like tunnel vision, blurred vision. But then symptoms can be pretty subtle as well, like feeling generalized weakness, or feeling tired, not thinking as clearly, or your concentration is like affected. And then there's this kind of like a neck pain, headache kind of symptom, which you call like the coat hanger headache, which they think is due to just decreased blood flow to muscles, in the shoulder and neck area. And the symptoms normally improve when you lie down or you sit back down. So I'm just gonna go through kind of what we do stepwise if someone's complaining of orthostatic hypotension. The easiest thing is to review medications, seeing what can be causing it or what can be worsening it. So especially blood pressure medication, especially the water pill like HCTZ, that can make it worse. Prostate medications, so medication used to treat BPH, like terazosin or prazosin. Erectile dysfunction medications, and even levodopa. Opioids or narcotics, and antidepressant medications can itself cause orthostatic hypotension or worsen it. And then educating the patients about what can provoke orthostatic hypotension or make it worse. So, if you've been sleeping for the whole night and then you sit up, that's usually when it's worse. So early morning can be a trigger. Body warming, so taking a warm shower where warm shower or warm weather where the blood, like the cardiac output or how much the heart pumps out decreases because the skin is being the blood is going to the skin. Postprandial, so after eating, can be another provoking factor. Exercise or even alcohol. So it's important to change medication and avoid the triggers. If that doesn't help, we can move on to non-pharmacological measures. One thing to try is what we call gradual or stage movement. So trying to get up slowly. So if you're in bed, sitting up at the edge of your bed for a few minutes before you stand up, wait there a few minutes until you feel better, not feeling dizzy or lightheaded, and then stand up. Same thing like going from sitting to standing, just stand for a few minutes if you can before moving, especially if you have orthostatic hypotension can help. And this allows for body to adapt, what we call autonomic adaptation. There's this physical counter maneuvers you can do. So just some exercises that you can do when you have these symptoms, and these work by reducing the blood in your periphery, so like in your legs, from pulling, and increases the cardiac output, so how much the blood the heart pumps out, which can help with the orthostatic hypotension. So things you can do is this, like standing on your tiptoe, so the toe lift is what I call it, or toe rise. There's the leg cross, the forward bend, you can do a step up. There's the genuflexion contraction, kind of like kneeling like that, and then squatting. So those are things you can do. Compression stocking can help by also reducing the peripheral, like pooling blood in your leg. It's one of the easier things you can do, but I know for some patients it's difficult to put on these socks because it is pretty tight. Abdominal binders is another way to reduce peripheral blood circulation in the gut, and also it might be uncomfortable as well. But one of the easier one is to change diet, so increasing fluid and salt intake. So one thing you can try is leaving a glass of water at the bedside so you can drink it before you wake up or before you get up for the day, or drinking a glass of water every meal. The goal is to get to about 8 cups, and this is only for patients without heart failure or other reasons why you have to restrict your fluid intake. And then bolusing or drinking 2 glasses of water before sustained physical activity can help. You want to liberalize salt intake with meals or salt supplements. So like eating salty chips will work too. Or adding a little bit more salt to your diet. And if you're having these symptoms after eating, what we call postprandial hypotension, one thing to try is taking smaller meals, or smaller but frequent meals that are low in carbs, and again, avoid alcohol. And if those non-pharmacological methods don't work or not helping enough, then we can move on to medications. So there's Midodrine. It's can cause this thing we call supine hypertension, so like the opposite. So the blood pressure goes up when you're lying down. So for this medication, we recommend taking it in the morning or in the afternoon, but avoid taking it after 6 p.m. for that reason. It can cause scalp itching, goosebumps, or difficulty voiding. Another medication is called fludrocortisone or Florinef, and this is an off-label use, but it's commonly used to treat orthostatic hypertension. It's more convenient than Midodrine in that it's a once daily medication, but again, can also cause supine hypertension, can also cause low potassium level and swelling in the legs. A newer medication is called droxidopa, and it might sound familiar because it is similar to levodopa, except for just some chemical structures slightly different, but it doesn't have like the effects, the motor benefit of levodopa, but it can help the blood pressure, and there's less risk of the supine hypertension with this. And then pyridostigmine is another medication that's off-label. It has weaker effect than these medications, so it can also be used in addition to Midodrine or low-dose Midodrine. The positive thing about this is it doesn't cause supine hypertension. Side effects include slowing the heart rate and GI symptoms like abdominal cramps and diarrhea. And I'm going to do a little plug for one of the studies that I'm participating in. It's called Neuroderm. The study is called Boundless. You know, they always come up with clever acronyms for it. But this is an investigational drug, ND0612, which is given continuously through a skin via a pump, kind of like this. And the aim is to reduce motor complications, so, you know, like on-off or the dyskinesias. They did a phase 2 study that showed reduction of off time compared to placebo. And right now, UCSF is participating in a phase 3 study, which is like phase 2 is seeing if it improves versus some other medication or placebo. Phase 3, we look at if it's effective and how safe it is and how tolerable it is. Compared to this medication compared to levodopa, oral levodopa. So to be eligible for this study, you have to be at least 30 years of age and taking at least 4 doses a day of levodopa. So that could be in the form of Sinemet, IR, CR, or Rytary, or other formulation of levodopa. And then experiencing a minimum of 2 to 2.5 hours of off time per day. So not just like each period, but like total throughout the day. And if you're interested in getting more information or hearing more about the study, you can email the coordinator. His name's Aaron Visor. That's his email here. And then there's a link here for more information from the company that's running the study. Okay, and thank you for your time.